Moving on to the next lecture. The topic of the lecture will be, can MRI replace prostate biopsy? Over to the moderator to introduce the revered speaker.
My pleasure to invite Dr. Sasikumar. He's a consultant urological surgeon from District General Hospital, Chilo. He's going to talk about, can MRI replace prostate biopsy? Over to you, Dr. Sasikumar.
Good afternoon to you all. And here the topic is, can MRI replace prostate biopsy? So, looking at the background, the aim of the prostate cancer diagnostic pathway is to increase the detection of clinically significant prostate cancer. That means Gleason score of 7 or above. At the same time, we want to reduce the detection of clinically insignificant prostate cancers that is unwanted at this point. So, the traditional prostate cancer diagnostic pathway initiated with the abdominal digital examination or RAISE TPSA proceed with the prostate biopsy that is going to be a systematic biopsy. As we all know, the PSA lacks specificity and it leads to unnecessary biopsies and risk of overdiagnosis of these insignificant cancers, at the same time missing the significant prostate cancers. So, we try to adapt some risk stratification with risk calculators in addition to these PSA values to modify the prostate biopsy to proceed with the prostate biopsy. But even though we are lacking behind certain things. So, with the introduction of MRI, MPM, multiparametric MRI, we try to do more with the prostate cancer diagnostic pathway. And in addition to the multiparametric MRI, we try to include MRI-based risk stratification with risk calculators and prostate health index or PSA density to, again, to modify or streamline the prostate biopsy. Here, we try to go for a targeted biopsy in addition to systematic biopsies. So here we are worried about biopsy for certain reasons, because it is invasive. At the same time, the biopsy has associated complication or morbidities to the patient, and diagnosing of insignificant prostate cancer, sampling errors, and in addition to that, it gives rise to cost and work burden to the health staff. So here the role of multiparametric MRI in diagnosing significant prostate cancer, it suggests the presence of the prostate cancer and allow us to do the targeted prostate biopsies. At the same time, it provides some staging information. With regards to clinically insignificant prostate cancer, it avoids the biopsy and avoid the biopsy. So we all know the PROMISE study in 2017. It is the practice-changing study with the introduction of multiparametric MRI in the prostate diagnostic pathway. Here the pre-biopsy MRI resulted in 18% of more cases of clinically significant prostate cancer detected when we compare to with trust biopsy alone. And at the same time, if the MRI is negative, we can avoid simply 27% of biopsies. And at the same time, it prevents the diagnosis of lower risk cancer in about 5%. With this practice-changing study, the introduction of MRI is rationalized and it is included in the routine diagnostic workup. Again, the precision study in 2018 that again confirmed the role of MRI pre-biopsy and in addition to that, targeted biopsy as well. So here the question is, to whom to biopsy and to whom we have to avoid the biopsy. And the role of MRI prostate on taking the decision of biopsy. So while considering the role of MRI in prostate biopsy, we have to think about the accuracy of MRI. So in this pathway, when the MRI is positive, it is highly dependent on the positive predictive value of the MRI or the sensitivity. So MRI and the clinical, when we consider the MRI and the clinical significant prostate cancer, it has good diagnostic diagnostic accuracy. It has a sensitivity of 93% when we consider the PIRATS 3, 4, 5 lesions. At the same time, when histologically seen IOCP grade 2 or more prostate cancer, it has a good sensitivity, especially when their diameter is more than 1 centimeter. When we consider the IOCP grade 2 cancers, MRI pool sensitivity is 0.91. At the same time, it increased to 0.95 when we consider the IOCP grade 3 or more cancers. So when we consider the MRI with regards to tumor foci, small tumor foci, the sensitivity is moderate because it can miss small tumor foci, but those particularly missed lesions are less than 1 centimeter most of the time. Again, MRI can underestimate the tumor grade and the volume because of the multifocality of the prostate cancer. So, but most probably it is uncommon with the grade 4, 5 lesions. So, therefore, here the utility of systemic biopsy and targeted biopsy in addition to MRI should be considered. So, to say when the MRI is negative, the key question here is whether the men are to be discharged without biopsy. So to consider that, we need to think about the negative predictive value of the multiparametric MRI. So after the negative MRI, shall we avoid biopsy? Here the concern is, are we missing some clinically significant prostate cancer? And then we have to think about the negative predictive value of multiparametric MRI or false negative multiparametric MRI, and whether still need to proceed with the biopsy when the MRI is negative. And at the same time, we have to consider how to improve the negative predictive value of multiparametric MRI. So with the negative predictive value of multiparametric MRI, it very depends on the clinical study design, cancer prevalence, and definitions with regards to positive MRI and the clinical significant prostate cancer. For pre-biopsy MRI, we need to have some risk stratification, and at the same time, when the MRI is negative, we have to define the patients to whom we have to omit the biopsy. So with a negative predictive value MRI, the PIRATS 2 or lower finding, it has the negative predictive value of nearly around 96% with regards to clinically significant prostate cancer. That means MRI has somewhere around false positive rate about 6.5% overall for the clinically significant prostate cancer. So with the results of MRI, we can't definitely exclude any clinically significant prostate cancer. So here we need to consider how to improve the negative predictive value of MPMRI, as the MPMRI is an important tool here in deciding on biopsy and streamline the diagnostic pathway. So here we need to consider the high quality multiparametric MRI. It has some factors related to scanners and the patient factors. And we need to have some experienced uroradiologists. They can interpret these multiparametric MRI. And reported images should be according to the latest PIRATS criteria. And we need to consider the artificial intelligence in reporting and interpreting the MRI that is vastly studied nowadays. So even though the multiparametric MRI is in place, we are come across a lot of clinically insignificant prostate cancer nowadays. The reason behind, even though multiparametric MRI is negative, as long as it's considered to have significant false negative rates, and in addition of risk stratification, which rationalize the use of biopsy, we go for a systematic biopsies, and we find out a lot of insignificant prostate cancers. And in addition to that, as long as in Sri Lanka we have limited availability to the multiparametric MRI, we proceed with the trust biopsy, depend on the PSA and the risk stratification. So we try to come across a lot of insignificant prostate cancers. So even though the MRI is less sensitive, is a good thing here, the MRI is less sensitive to IOCP grade 1 cancers, that is, we consider clinically insignificant. And when we consider the multiparametric MRI with regards to active surveillance, it's an important tool in those patients with active surveillance. It is at the time of diagnosis, with a multiparametric MRI, we try to select the patient to go for active surveillance. And during the surveillance, to follow up the patient, we try to avoid the biopsy, and we try to follow the patient with the PSA and the multiparametric MRI. And owing to existing limitation with the multiparametric MRI, it cannot fully replace the biopsies in the context of active surveillance. So the follow-up after multiparametric MRI, the intermediate oncological outcome, after 4 years, nearly less than 10% only progress to clinically significant prostate cancer. That is also associated with PSA velocity of more than 0.27. So the PSA monitoring is a reasonable option when the multiparametric negative MRI in those patients. So even though the multiparametric MRI we considered as an important tool in the diagnostic pathway, here in Sri Lanka, we have limited availability. Even though in United Kingdom, they considered only 62% of men who need a prostate MRI in UK get one at one point. So it's a limited, demand is high, but even though supply is less. So, and the cost is much more, and it needs a contrast agent, and it is time consuming. So consider those things. The current study, it's a prime study in 2024. It is presented in the European Association Urology last annual congress. The prime study that compared the multiparametric MRI with the biparametric MRI. It found there is no difference in clinically significant or insignificant prostate cancer detection, no increase in biopsies, no difference in specificities or false positivities. There are some minor differences with regards to treatment eligibility and the treatment planning. But it is cost effective, and it doesn't need contrast and less time. And so considering that, it ensuring every man who needs an MRI scan will be able to get a MRI scan. So it is one of the strategy we can adopt as a Sri Lankans that is more cost effective and less time consuming. So at summary, the aim of this prostate cancer diagnostic pathway is to diagnose the clinically significant prostate cancer, not the insignificant prostate cancer. Here the negative predictive value MRI is the key in avoiding prostate cancer biopsies. So therefore we have to consider improving the negative predictive value of MRI. At the same time, we try to adapt some risk stratification tool in order to streamline the biopsy. Therefore, we can diagnose the clinically significant prostate cancers and avoid the diagnosing of clinically insignificant prostate cancers and negative biopsies. Thank you.
Thank you, sir. Let me invite one of the moderators to present the token of appreciation to Dr. S. Sasikumar.